for surgery at PGI Chandigarh. But for political reasons and other reasons, he was not given a seat in surgery. And thankfully, he took up anesthesia. And that was a good thing for the field of anesthesia. After finishing his degree at PGI Chandigarh, he worked sometime as a senior resident at Jipma Pondicherry, then moved on to Civil Criminal Institute at Trivandrum, and then came to his main institute at Thota Medical College, Manipal. He was there for over 23 years and brought Manipal onto the academic map of anesthesia. He was an astute leader, a terrific teacher, an upright man, a great reader. Her vocabulary was tremendous. Although his medium of instruction was Telugu, he had extraordinary English and he picked up so many languages, including Kannada. He used to read the Kannada newspaper every morning, which he brought up in Karnataka, not able to read. Such was his tremendous knowledge, and his wisdom was endless. I was associated with him since 1978 when I joined as a student at Manipal, doing my diploma in anesthesiology. And from him, he was sort of a friend, a teacher, a mentor for me for all those years. And I was associated with him till his final days. While we deeply remember him and his legacy and spirit will continue to live in our hearts. That was a great Dr. P.N. Thota, and we all cannot forget him forever. There are so many other adjectives to describe, but it would not be enough. So, thank you once again for the committee for selecting me to deliver this oration. And the topic I've done today is neurological complications following peripheral nerve block. Now, do newer techniques reduce these complications? When I started giving peripheral nerve block, thankfully there is no timer on this. So, I had a lot of issues when giving peripheral nerve blocks, in the sense that the duration of these blocks were so long. And many times, I got calls from surgeons saying that the patient is unable to move the limb even after 24 hours. And that put a lot of stress on me as well, because I will wonder whether have I produced some nerve injury. And after a duration of surgery which just lasted about 1.5 to 2 hours, and the block continued for 24 hours, the patient also was very much worried that he is not able to move the limb. And even in the middle of the night, when the patient used to complain, I would rush to the hospital to see whether I have produced a peripheral nerve injury. So that sort of made me read more in detail of what is this peripheral nerve injury. But before we go into that, we'll just go a bit of introduction of regional anesthesia. Now we all know that the various advantages of regional nerve blocks, and since COVID-19, regional anesthesia has regenerated. We all know during the COVID-19 period that we all wanted to avoid general anesthesia. We all wanted to avoid giving intubating, giving intravenous anesthetics, doing the laryngoscopy, we wanted to avoid. So we thought of going more and more into regional anesthesia. And of late, probably it has gone to the other side, where people started giving, thoracic spinal anesthesia for all surgeries. I've never done a thoracic spinal, but I think many youngsters would still favor, even for a laparoscopic surgeon, they give thoracic spinal anesthesia. I am not that confident of giving thoracic anesthesia, but it has gone to that extent since COVID-19. Now you see there are several advantages of giving, and the main thing is tremendous pain relief and lesser use of opiates. And this, because we use less and less opiates, it produces lesser nausea, vomiting, and since it produces lesser nausea and vomiting, the patient is to take only very quickly post-operatively. These patients will be fasting overnight, and then the duration of surgery, they'll be sort of literally hungry, as probably you would be in probably another half an hour. You're already late. So, regional anesthesia offers several advantages. They are mobilized earlier, they are able to move, they are able to walk. And in the Indian scenario, very decreased economic costs. Whenever the patient comes for surgery, the first thing they ask is, what is going to be the expenditure? And with regional anesthesia, definitely the costs come down. Now the other great advantage of regional anesthesia is the greenhouse effect. What we go regional. Okay? We know that inhaled anesthetic agents and nitrous oxide, when they are exhaled into the atmosphere, they sort of trap energy within them and prevent heat being released into the atmosphere. This entrapped heat causes rise of temperature on the surface of the earth. Now the half-life of these inhaled anesthetic agents is more than 100 years, more than our lifespan. And this causes a tremendous increase in the rise in temperature on the surface of the earth. And among them is gas fluorine, which has the potential to raise the temperature by more than 3,500 times. Of course, I have never used gas fluorine, and the use of gas fluorine also has come down over the period of years. And as far as reducing the effect of green effect is the use of total intravenous anesthesia. Now, even total intravenous anesthesia, the manufacturing of intravenous anesthetic agents, the manufacturing of plastic syringes, they all have a tremendous greenhouse effect. So even then, the total intravenous anesthesia will not prevent a greenhouse effect. The only way is to go totally regional. Now I try to divide the lecture into 3 or 4 parts. We go with the definition of nerve injury. What is this injury? Basically, we'll have to know the structure of a nerve before we can describe what is a nerve injury. What are the different types of nerve injuries, the mechanism, the symptoms, and has our anesthetic technique reduced the incidence of nerve injury? Now, as the definition goes, it is a new onset of sensory or motor deficit consistent with nerve plexus distribution, and one of the following: an electrophysiological evidence of nerve damage. You do electro nerve conduction studies and you find that there is problem in transmission of a nerve impulse. Or there are new physical signs. The patient has developed a motor weakness or has developed a new onset pain, or there has been persistent paresthesia, in this nerve distribution which lasts more than 4 to 5 days. Now in the context of nerve injury, it is a broad spectrum of abnormal nerve dysfunction. And this nerve dysfunction, if persists for more than 48 hours. Now why do we take 48 hours? Because we expect our nerve block to last for more than 24 hours, and given a period of time, we take it as 48 hours. By 48 hours, your nerve block effect should have subsided. If it extends beyond 48 hours, it should be classified as a nerve dysfunction. So that is the basic definition. Now as far as incidence goes, now when we take a consent of a patient and we tell him that you will be given a nerve block, you have to mention to him what would be the amount of dysfunction, what is the incidence of nerve dysfunction. Now many times we do not know exactly what is the nerve dysfunction because we do not practice it routinely. Say if you are giving a general anesthetic, you would tell him that you would develop this amount of sore throat, you would develop a bit of cough, you would have nausea and vomiting. But when it comes to nerve dysfunction and you are planning to give a nerve block, you probably would have no idea what would be the incidence of nerve dysfunction. Now, the temporary and permanent incidence. Now, the incidence of nerve injury is extremely less. 0.2% at the end of 1 year. Now, why do we worry at such a low incidence of nerve injury? Because if you have even one case of permanent nerve injury, it could upset your lifetime. Even one permanent nerve injury can cause a lot of dysfunction for the patient, especially if his occupation is such that he uses his hands. He's a computer specialist. It could affect him very much. Say for instance, you are giving a general anesthesia for a professional singer and you produce a vocal cord injury, you change his voice, it's going to affect his occupation. Similarly, even one nerve injury can upset your practice, can affect his life. So, although the incidence is very, very less, you should be aware of it. Now, temporary nerve injury immediately after the block can last a few days, and the incidence is quite high. Nearly 15% of individuals can have some amount of paresthesia lasting nearly 15 to 20 days. So, as the duration of post-block goes on, the incidence sort of comes down and he slowly recovers from the nerve injury. But permanent injury, one needs to try and avoid. Now coming to the basic structure of the nerve, which you should know. Now the nerve comprises of several vesicles, and these vesicles are united together by an outer layer called the epithelium. Now, surrounding each vesicle is a layer called the perineurium. You have the epithelium and then you have the perineurium. Now, inside each vesicle are individual axons, and each axon is covered by a layer called the endoneurium. So you have the epithelium, the perineurium, and the endoneurium. Now the epithelium is a porous or a permeable structure where fluids can leak from the epithelium into the perineurium. Whereas the perineurial cells are all have tight junctions which prevent chemical agents and fluid from entering into the perineum. Similarly, the endothelium, they have capillaries which are non-fenestrated and prevent fluid from leaking into the axon. Now this is something like a blood-brain barrier which allows fluid from entering into the epithelium but prevents fluid from entering the perineum. Okay. So this is the basic structure. The amount of vesicles in each nerve varies. As you go centrally, the amount of vesicles are more. Say, when you give an intrascaleral block and you give the injection into the C5, C6 route, the amount of vesicles are large and the amount of fibrous and connective tissue is less. As the nerve travels distally, the amount of connective tissue increases and the number of vesicles decreases. Now, when the injection is made inside the epithelium but outside the perineum, it is called an extravesicular block. You are giving the injection outside the vesicle. And when you give the injection inside the vesicle, you penetrate the perineum and give it inside the vesicle. It is called an intravesicular block. Now the degrees of injury, the earliest or simplest one is the neuropraxia, where there is damage which is limited to the myelin sheath, only to the myelin sheath, but not to the axon or to the endothelium. And here, the usually caused by a stretching of a nerve or a compression of a nerve, and the outcome in neuropraxia is excellent. You have a bit of paresthesia for a couple of days, and the most important thing here is the recovery is complete. After a couple of days, the recovery is complete. Then you have the axontomesis, and as the nerve suggests, where there is damage to the axon and there is a discontinuation of the continuation of the axon. This is the most serious injury, and the recovery can be incomplete, and the duration of recovery is very much prolonged. That is axontomesis. No. And the worst thing is the neurotomesis. As the name suggests, the nerve is completely divided, the prognosis is very bad, and usually you require a surgical intervention to repair the nerve. So neuropraxia, axontomesis, and neurotomesis. Now, nerve injury as such is complex. It is not only because you have given a nerve block. There are multiple factors which cause nerve injury. And I am going to talk to you basically only related to a peripheral nerve block. Now, one is the traumatic, where the needle comes in contact with the nerve, where we used to practice it in the early days at a paresthesia technique, where you intentionally touch the nerve and cause paresthesia. That is the earliest form of traumatic nerve injury. But even when you are giving a nerve block using a peripheral nerve stimulator, or even if you are using ultrasound, you may unintentionally touch the nerve and cause paresthesia, which can cause nerve injury. The other one is ischemic. Ischemic, when you cause an intraneural injury, when you inject a local anesthetic and you give a large volume of local anesthetic. Now we have a tendency to give very large volumes. Now with the practice of ultrasound, we have reduced the volume of local anesthetic. But initially, when using a paranesthesia technique or a nerve stimulator, 30 to 40 ml was very common in giving a supraclavicular block. It was very, very common. We give really large volumes. And this large volume can cause ischemia by compressing the capillaries. Second is producing an hematoma. You injure a blood vessel while doing a nerve block, and this hematoma compresses the plexus of the nerve, causing ischemic injury. Damage to supplying of vessels and the use of adrenaline. We still use adrenaline in 200,000 concentration, and this causes vasoconstriction and can cause nerve injury. So many people sort of have stopped use of adrenaline. We use other areas which help us in avoiding adrenaline. Or many times they use more dilute concentration. You can use 1 in 500,000 concentration, which can have a less vasoconstrictive effect on the capillaries in the nerve. Neurotoxic. Remember that local anesthetics are neurotoxic, and greater the concentration of local anesthetic one uses, greater is the effect of nerve injury. Now, we use 2% lidocaine with adrenaline, or we use 0.5% bupivacaine. Many times, such high concentrations are not necessary for a nerve block. Many use 0.75% bupivacaine, which is really not required. A 0.5% bupivacaine is good enough for a block. And lesser the concentration of a local anesthetic, lesser is the incidence of nerve injury. And inflammatory is reaction to the local anesthetic, which can occur outside the nerve. Now, symptoms are very simple. You may have paresthesia, you may have abnormal sensations in the upper limb, and you can have motor weakness. Now, most of us, I think majority of us practice upper limb blocks. Very few within this audience practice lower limb blocks. I'm sure 90% of us practice only upper limb, very few of us lower limb. Because, why is the reason? Because in lower limb, we can get away with a single shot spinal anesthesia, we can get away with an epidural block. But many times, we need to give lower limb blocks, especially in patients with severe cardiovascular disease, patients with cardiomyopathy, and various other factors. But majority of us practice only upper limb blocks. So most of the studies are related to upper limb blocks, but few of them still practice lower limb blocks. Now, the other thing is recognizing that the patient has got peripheral nerve injury. What are the various factors? Barriers to recognition. One is patient is sedated, patient has post-op pain. Although he is having nerve injury, he may be having paresthesia, dysesthesia. We think that it is because of the post-operative pain. Or we give a lot of analgesics and the symptoms disappear temporarily. Once the effect of analgesic goes, the dysesthesia or paresthesia returns. Failure to report. Patient thinks that the symptoms are because of the nerve block one has given. And the anesthetist and the surgeon think, because you are given a block, those are the symptoms. Patient, of course, patient is not educated, so he will not realize. He thinks that this is because of the block and the patient's the sensation and the motor power will return. Post-operative activity restriction, these patients have plaster of Paris, they are cast, especially if you are given a lower limb block, they are still in the cast and they are not able to move. So they don't realize that the patient has got nerve injury. And especially concerning ambulatory surgery, When you give a block in the morning and the patient is discharged by the evening, there is no follow-up, the patient doesn't follow up, you do not follow up, and the patient continues to think that the effect is because of the block. So, a lot of things that we do not recognize the symptoms of nerve injury. Now, why are we worried about this is because of the nerve injury, which can cause a lot of dysfunction and motor weakness. Now, what we are mainly worried is because of an intraneural injection. Now, what is an intraneural injection? Now, anything under the epineuron. Now, as I described before, a nerve consists of three layers: the epineurium, the perineurium, and the endoneurium. Now, there are various descriptions of what constitutes an intraneural injection. Now, some say you should give it under the perineum. Some say you should give it only inside the vesicle. But since a nerve is covered by a neural layer called the epineurium, anything under the epineurium should constitute an intraneural injection. So one must avoid giving any local anesthetic under the epineurium. Now, why is that so? Why are you afraid to give an injection under the epineurium? That is because studies have shown that any injection under the epineurium causes inflammation and causes histological changes to the nerve. Be it a local anesthetic, be even ordinary saline, or be a nerve coming in contact with the epineurium. All these produce nerve injuries, neurological changes, and inflammation. So one must avoid giving an intraneural injection. So basically, nothing under the epineurium and definitely nothing inside a vesicle. So while giving a nerve block and using a nerve stimulator, if you are able to stimulate the nerve with a very low stimulating current, say less than 0.5 milliamperes, if you are able to stimulate a nerve with very low current, less than 0.5 milliamperes, or there is pain during injection, or you are getting it very difficult to inject the local anesthetic. All these three things means that you are giving the injection intraneurally. And many times we have realized that your block has worked within a couple of minutes. Within 3 to 4 minutes, the orthopedician has already started lifting the limb and started cleaning the arm, and the patient being absolutely comfortable. Remember that it has been an intraneural injection. Otherwise, a nerve block should not act so rapidly. If you are given an intraneural injection, the nerve block onset is extremely rapid. Now, coming to the three basic techniques and how these three techniques cause nerve injury. We all, my generation of people, started with paresthesia technique. Then we went on to nerve stimulator techniques. And now the younger generation has moved on to the newer ultrasound techniques. Now let's see how these three techniques affect. Now paresthesia is basically produced when a needle comes in contact with the nerve. This can be intentional if you are practicing a paresthesia technique, or it can be unintentional when doing a nerve stimulator technique or you are doing an ultrasound technique, you can still touch the nerve and produce paresthesia. So it is not when you are doing a basic paresthesia technique only you can produce paresthesia. Unintentionally also one can paresthesia. But ideally one should avoid touching the nerve because this nerve needle contact can produce nerve injury. So I think paresthesia technique more or less is gone out of practice, but many people I still see they work in smaller rural centers and they say we do not have a nerve stimulator, forget an ultrasound. So many of them still practice paresthesia technique. I think as far as possible we should try and avoid paresthesia technique. Now coming to perineal nerve stimulator. Now electrical nerve stimulation is used extensively to facilitate and enhance peripheral nerve blockage. Studies which have shown using peripheral nerve block techniques have shown a lot of success. Not only a lot of success, but they have to be able to repeatedly stimulate a peripheral nerve. Now, the basic concept of the peripheral nerve stimulator is an electrical current is released from the tip of the needle, and this depolarizes a nerve, which is basically a mixed nerve or a motor nerve, and this depolarizes the nerve and causes a muscle contraction. Now, as the needle gets closer and closer to the nerve, lesser and lesser current is required to stimulate the nerve. So that is the basic principle. Now all of this basic principle is so easy. Fundamentally and practically it is much different. That one must remember. Now when you compare it to paresthesia technique, with a nerve stimulator, you are going to get a visual feedback. You see a particular muscle contracting. In a paresthesia technique, the patient, you tell the patient that you are going to get something like a shock sensation in your arm. Whereas here, you are going to get a muscle contraction. Patient is very comfortable. I remember when you do a paresthesia technique and you tell a patient you are going to get a shock-like thing in your arm, he immediately becomes very anxious, he becomes very tense, he holds his arm very stiff, because when you tell a patient you are getting like a shock-like thing in your arm, even I will be afraid. Whereas with a peripheral nerve stimulator, you don't require that, he is very comfortable. Of course, sometimes when you get very violent contractions, the patient can become a bit anxious. And since you know which muscle is contracting, you also know which nerve is being stimulated, and you know that your needle is very close to the nerve. So there is some amount of accuracy, patient is comfortable, and you are getting a feedback. Paresthesia, what happens is, it's sort of a vague symptom. Sometimes you ask, are you getting it? They will say, no, I'm getting some sensation in the neck when you're giving a supraclavicular block. So it's not really very clear whether the patient is really getting a paresthesia or not. Whereas with the peripheral nerve stimulator, it is reasonably accurate. So the success to a technique is, as the needle gets closer to the nerve, lesser current is required to stimulate the nerve. Now, how much current is required? How much current is required to stimulate the nerve? So several studies have been done there. So the initial studies was way back in 1969, where they stimulated the obturator nerve in eight patients. They gave about 13 obturator nerve blocks. What they did first is, using a landmark technique, they used a blind procedure. Usually we don't call it a blind procedure now, we call it a landmark technique. Using a landmark technique, they brought the needle very close to the obturator nerve. Once they brought the needle close to the obturator nerve, they used fluoroscopy and tried to locate where the needle tip was. And in the majority of the patients, the needle tip was very close to the obturator nerve. Once they did that, they used the peripheral nerve stimulator and stimulated them. Now in 11 of the 13 blocks, they could stimulate the nerve with a current of 0.5 mA. With the 0.5 milliamperes, in 11 of the 13, they could stimulate a block. And this sort of became a standard of using 0.5 milliamperes as the current required to stimulate a motor nerve. What importantly they also found was that a very small amount of local anesthetic was required to stimulate the nerve. Whereas in the other two patients, they required more than 1 milliampere, and they also required larger volumes of local anesthetic to block the nerve. So this sort of became a standard of using 0.5 milliamperes and lesser to stimulate the nerve. Now the question we have to ask is it true that if you require to produce a response, that is a motor response, or fail to produce one when the current value is more than 0.58, the probing needle is far away from the nerve plexus? So, for an example, I would say, if you require 1 milliampere to stimulate the nerve, then the needle is far away from the nerve or the plexus. The question is, if you require more than 0.5 mA, then the needle is far away from the nerve or plexus, and you need to get closer to the nerve. Is this true? According to the previous study, a 0.5 milliampere should be able to stimulate the nerve. But is this true? Now I'll come to a couple of studies. Now in this study, where they used 103 patients who were enrolled for the study, and they used the axillary block, and they used all the three techniques: paresthesia, nerve stimulation, and ultrasound. And first they used ultrasound, and they visualized the nerve and brought the nerve very close to the axillary plexus. It could have been the ulnar nerve, it could have been the median nerve, or it could be the median nerve. It could be any of that. So once they brought the nerve close and the needle was in contact with one of these nerves, they asked the patient whether they had any paresthesia. That was the first question. The second thing what they did was, they then stimulated the nerve with 0.5 milliamperes and saw whether there was any motor response. Now, as far as paresthesia was concerned, only 38.2% patients reported paresthesia. Now, although the needle was in touch with the nerve, only 38% of patients, that is approximately 40 patients, reported paresthesia. Whereas the rest of the patients did not report paresthesia in spite of the needle tip touching the nerve. Now coming to nerve stimulation, only 74.5% patient, percentage of patients where you could elicit the motor response. Whereas the rest of the patients, nearly 36 patients, there was no motor response despite the needle tip touching the nerve. So is this 0.5 valid? Is this 0.5 valid? Now another thing what they did was, they used the sciatic nerve and they used the nerve stimulator. They stimulated the nerve with 0.5 milliamperes, and once they got a response, they injected 40 ml of local anesthetic. As I was saying earlier, the practice of using large volumes of local anesthetic was there earlier. This itself can cause nerve injury. And they used 40%, 40 ml. And then what they did was, using ultrasound, they first measured the diameter of the sciatic nerve, and after injecting 40 ml of local anesthetic, they again measured the diameter of the sciatic nerve. Now, what they saw was, when they got a motor response using the peripheral nerve stimulator, most of the needles were located intraneurally. Now, our basic aim in preventing nerve injury is that we must prevent an intraneural injection. But what we saw here is that when we elicited a response of 0.5 milliamperes, the needle was already intraneural in nearly 78% of cases. And that is what we want to avoid, but it was inevitable. Even using a peripheral nerve stimulator, it is difficult to avoid an intraneural injection. Now, the other study was, they used low stimulation in 24 patients, and what they did was, they stimulated the nerve. Either they stimulated the nerve and they got a response, or they used ultrasound and found out whether the needle was intraneural or not. Now, what they find was, in 20 of the 24 patients, only when the needle was intraneural did they get a response to nerve stimulation. Only after the needle entered inside the nerve did they get a response to nerve stimulation. In 20 patients. So the needle was already intraneural when you got a stimulus to nerve stimulation. And in 4 patients, they could not elicit a motor response even with more than 1.5 milliamperes. Even when the needle was inside the nerve, they could not elicit a motor response. So you see, the nerve is really a complex structure which we have really still not fully studied. Now in this study, they used pigs. They used 20 pigs. They exposed the sciatic nerve on both sides. And what interesting study they did was, they placed the needle at various distances from the sciatic nerve. 2 centimeters, 1 centimeter, 0.5 centimeters, 0.2 centimeters, 0.1 centimeters on the epithelium and inside the epithelium. So they studied the various differences and stimulated the sciatic nerve. Now what they concluded was, with 0.2 milliamperes current, the tip was intraneural. When the tip was intraneural, the current needed to stimulate the nerve was 0.2 milliamperes. That's why they say you should not inject a local anesthetic when you get a motor response at 0.2 milliamperes. You need to withdraw the needle. You should never inject a local anesthetic if you get a response at 0.2 milliamperes or less. But in 12.5% of patients, even though the needle was intraneural, they could not elicit a response. Now, one of the conclusions from all this is that even though your needle is intraneural, you may not get a response. So what is the tendency you tend to do? You still try to probe. You still try to probe the nerve to get a response. And you are already intraneural. So the chances of damaging it are no? So it is sort of a complex situation. You don't get a response at 0.5 milliamperes, but you are already intraneural. Fortunately, the incidence, as I said, of nerve injury is very, very less, and most of the time you get away, but sometimes you can land in problem. So the summary of PNS was intraneural placement is very common. You may agree or not, whatever technique you use, most of the time your needle will be intraneural. Motor response only to high current when you are intraneural. You are intraneural, but your nerve stimulation will only be at high current. They will never stimulate, you will never get a response at low current. And this is especially seen when patients who have coexisting disease. Patients with diabetes, they say, you require a higher current to stimulate the nerve.
Correct.
So remember that. So what conclusions you draw is, should the bar of stimulating a nerve be elevated? Should we need not 0.5 at 0.75 or 1 milliampere? Should be the lowest level when you stimulate a nerve. And different nerves can have different values. Say for instance the sciatic nerve. Sciatic nerve is very large, and nearly 70% of sciatic nerve is covered with connective tissue and adipose tissue. So you may require a higher level of current to stimulate it. Say if you take the ulnar nerve, it has got very little connective tissue. So you may require very less current to stimulate it. So a day may come when you may have individual values for individual nerves. Now, we go to the last aspect. Now, the success to a nerve block is, one is identifying the nerve or the plexus you are going to block. Second is getting the tip of the needle close to the nerve or the plexus. And third and most important is you surround the nerve or plexus with a local anesthetic or whichever agent you want to do. So there are the three primary criteria. Now, with paresthesia technique, you do not know which nerve you are stimulating because paresthesia is a vague symptom and you do not know which nerve you are stimulating. Whereas with the peripheral nerve stimulator, you can identify which nerve you are stimulating. Placing the needle close to the plexus, with paresthesia what happens? Paresthesia occurs only when the needle is in contact. Once the paresthesia disappears, that means that the needle has moved away. How much it has moved away, we don't know. So the needle may not be very close to the plexus. Many times what happens, because of the severe paresthesia, the patient moves the arm or the limb and the needle moves away from the plexus. Whereas with the paresthesia technique, the nerve stimulator technique, you are still very close to the nerve plexus. And the third is surrounding the nerve with the local anesthetic. This many times with the nerve stimulator technique may not occur. And why this may not occur? Because the local anesthetic will flow, or all liquids for that matter, will always take the path of least resistance. And if we think that the electrical current has stimulated the nerve, the vector of the electrical current may not go according to what we want. It may go, the electrical current will go somewhere else. Because living tissue is not a simple tissue. It has got a lot of resistances and inductors and capacitors. You know? So you get a lot of resistance towards the nerve. The local anesthetic will go somewhere else. So it peripheral nerve stimulate fairly better than peripheral anesthesia technique, but not completely successful. That is why many times you may find some of the nerves that are not blocked. So we come to the last aspect, and that is the holy grail. I think many of us would have seen the movie The Indiana Jones and the Last Crusade by Harrison Ford, where he goes in search of the Holy Grail. Now, Holy Grail in Christian legend was the cup used by Jesus Christ for his Last Supper. Now, this cup was a magical cup, and in the medieval times, the knights used to go in quest of this cup. They went in search of this cup. Now, the Holy Grail in the context of medicine would be trying to find a vaccine for a common cold or a cure for cancer. That would be the Holy Grail. So it comes in terms of an unobtainable goal in the medical field. And in terms of anesthesia, in terms of regional anesthesia, Holy Grail would be producing peripheral nerve blockade with a local anesthetic which has a rapid onset of action, extremely long duration of action, 100% success, and no complication. That would be the Holy Grail in terms of peripheral nerve block. But this prize has still not been found. Nobody has been able to get this prize of the Holy Grail. Now, is ultrasound the answer? Is ultrasound the answer to the Holy Grail? Now, with ultrasound, you visualize the plexus. In most conferences, definitely there would be a workshop on ultrasound. Nowadays, no conference goes, that's the thing. The main thing is ultrasound. You can see it so easily. They put the probe and easy peasy, as they would say. You can see the plexus and the nerve. You just have to put the local anesthetic there. It's not that easy. You visualize the needle, you visualize the nerve, and you bring the needle close to the nerve. So your two criteria are there. You know which nerve you are stimulating, you see the needle, and you are bringing it very close to the plexus, and you can see the spread. You can see the spread so easily. So all the criteria of giving a 100% successful block are met with ultrasound. But can ultrasound prevent an intramural injection? We all know that an intramural injection produces nerve damage, and one at any cost must prevent an intramural injection. So, you are seeing the nerve with ultrasound, you are bringing the needle very close to the nerve, and you are seeing the local anesthetic spreading around the nerve. But still, can ultrasound prevent an ultrasound internally? Now this is a big study done in 2011 where they used 253 patients and they used this for shoulder arthroscopy in day care surgery where they used interscalene block and an acetabular block. They used ultrasound technique and they took a video of it and the two blinded anesthetists watched the video after the block. They were all blinded and following the block, they saw what was the incidence of intraneural injection. These are all experienced anesthesiologists. I thought there was no timer. When I saw there was no timer. Okay. So what they found was 17% was an intraneural injection. And how did they determine it was an intraneural injection? The size of the particular nerve root, whether it was C5, C6 or C7, had increased in size. So even with ultrasound, they found that 17% of individuals had an intraneural injection. Now what was the reason for this? One is difficulty in identifying the target. It's not that easy. You have soft tissue, you have muscles surrounding it, you have a lot of vascular structure, so it's not that easy to identify the nerve. Suboptimal nerve settings. Nerve settings play a very important role, which sort of most workshops will not teach you. Low-end US machines. Now, if an anesthesia department asks for an ultrasound machine, who will decide which machine you will get? It will be the radiology department. And the radiology department will say, you don't require such an expensive machine. This machine is good enough for a nerve block. I think that will be 95% true. What is that? You want to give only a nerve block. Why you want a 30 lakh machine? And you will get a low-end machine. And in a low-end machine, it will be very difficult for you to differentiate between the epithelial and the peripheral. Failure in fracture needle is very difficult, especially the tip of the needle. You need a good practice. It's not that simple. Poor echogenicity of a needle tip. Now you get very good echogenic needle, but many times the tip of the needle is not echogenic. Only the shaft of the needle is echogenic. So, unless you know where the tip of the needle is, you will definitely give an intraneural injection. And difficulty in distinguishing between an epidural and peridural. Now, the other thing is, I will come to the pressure. Now, while injecting, what can prevent an intraneural injection is a high pressure. Never give an injection under high pressure. Now, practices to reduce peripheral nerve injury. Patient selection is very important. Patient selection is very important. Coexisting disease. 3 important diseases: diabetes, hypertension, and tobacco users. Tobacco users is very prevalent, and so be careful. There is a high incidence of nerve injury. Avoid sedation, because many times when you try to inject intraneurally, there can be pain, and if the patient is sedated, that symptom will be abolished. Tracking needle with ultrasound, triple monitoring, ultrasound, nerve stimulator, and pressure monitoring. Hydrolocation, stop the injection if patient complains of pain, and use minimal concentration. Especially with ultrasound, you can use 50 to 20 ml. Use low concentration. You can use 0.5% wood weighting or less depending on the type of soil. So, what has been finally found is the incidence of peripheral nerve injury has not been reduced despite the use of ultrasound. Even using ultrasound, the incidence of nerve injury has not come down. Many people use peripheral nerve stimulator very well, much better than people who use ultrasound. So where does the future lie? There are various advanced modalities that have come to prevent nerve injury. Impedance monitoring. Now new nerve stimulators have come where you can monitor the impedance, electrical impedance. But the problem with electrical impedance is only when you puncture the perineurium, you will know the impedance. That means your needle is already inside the nerve, which itself can cause an injury. Okay? High definition imaging, electromagnetic needle tracking, acoustic radiation force, and tissue sensing technology. Now these technologies have been there for more than 5 to 6 years. So it's not very new, but practically it's very difficult. So let me thank everybody. I thank the organizers for giving me an opportunity to deliver this prestigious oration. And I thank the organizers also for the great hospitality that they have given here. And it is very nice to be in Tirupati. And thank you, Phanindranath.